So Dr. Bray is currently the interim dean of Oklahoma State University College of Osteopathic Medicine at the Cherokee Nation in Oklahoma. So she's going to talk about her work with the Cherokee Nation and how she teaches medical students to serve vulnerable populations and improve access to quality healthcare. So Dr. Bray, thank you for being here.
Thank you so much. Give me just a second to get my slides pulled up. All right, hopefully everybody can see my slides okay. My name's Natasha Bray, and it's always kind of fun to get to follow Brandon. He is one of our outstanding students on our Tulsa campus, and we are so proud of him and everything that he has done and his leadership throughout school. But he also, I think it's important to know, and he didn't share this, but even though he's a fourth year and he's already matched to emergency medicine, he is still out in communities and going to schools and taking a ultrasound course kind of on the road, really trying to inspire junior high and high school kids that this is possible for him. So we are very proud of the work that he is doing. As was said, I want to spend a little bit of time today talking about what we're doing at Oklahoma State and our partnership with the Cherokee Nation. So this is our campus. We have an 84,000 square foot building that we opened in January of 2020. The school itself opened in August of 2020. So August of 2020, the building opened in January of 2021. I apologize. We had some challenges with COVID, and I think that that's important to kind of understand and talk about, because I think it underlines and highlights the relationship between OSU and the Cherokee Nation. Our mission is really rural and underserved, and this is OSU's 50th anniversary of the medical school. The Tulsa campus opened to students in 1972, and really with a mission of training primary care physicians to serve Oklahoma's rural and underserved communities. And what grew out of that was outreach and partnership, a lot of community listening, a lot of how do we help different communities get physicians that are going to meet their community needs. And that was really what happened and was the start of our relationship with the Cherokee Nation. Cherokee Nation had self-compacted to manage W.W. Hastings Hospital from Indian Health Services in the mid-90s, and was looking for how do we get a sustained workforce available to support our healthcare center. A lot of things happened with Cherokee Nation Health. They put an emphasis and an importance on serving their communities and serving their people. And they went on a massive build out of a clinic system. Currently, there are eight outpatient healthcare centers, plus the healthcare center here in Tahlequah that's adjacent to W.W. Hastings Hospital. And they position those clinics in the community so that no one would be more than 35 miles from a multidisciplinary medical home. Most of their primary care healthcare centers have pharmacies within them. There's primary care. The majority of them also have pediatricians. They've got nutrition services. They've got optometry. They've got mental health services. They've got dental services. So really looking at around care, and what they kept running into was the barrier of not having a sustained physician workforce who were able to serve their population. So around 2005, OSU and Cherokee Nation started having conversations about having students on rotations out with their clinics, and using that as an opportunity, one, for OSU students to get exposure to working with American Indian and Alaskan Native patients, so that they began to develop more cultural competency in this arena. From there, in 2007, a family practice residency program was started in Tahlequah, and it was a partnership program. OSU was the sponsoring institution of that program, and that was a partnership between OSU, Cherokee Nation, and the community hospital Northeastern Health System here in Tahlequah. It was a small program, took 5 residents a year. In 2019, that program actually moved from being a consortium program to being based solely at the Cherokee Nation's outpatient healthcare facility. So really a lot of growth from a medical education standpoint. And what they found was that Cherokee Nation's health's mission of providing high quality access to care for their citizens matched very well with OSU's mission of training primary care providers to serve these underserved communities. So that partnership, that listening and that understanding of shared mission is what led to the formation of OSU COM at the Cherokee Nation. This is a quote from Principal Chief Hoskin at the ribbon cutting, and he said, as we mark the official opening of the first tribally affiliated medical school in the United States, we know that one day we'll look back on this day, and what will have mattered most is whether the efforts have changed the lives for the better. I believe this partnership will advance the quality of healthcare for all by allowing us to teach a new generation of medical professionals to serve our community for years to come. So that commitment on both the side of the Cherokee Nation as well as OSU was really important. So I said we opened in the middle of the pandemic, and that presented some challenges. So classes were scheduled to begin in August 1st of 2020, which, if everybody remembers, that was when we were still experiencing lockdown. So our facility was not ready to open. We were scheduled to finish construction in June of 2020. Our site was actually shut down for 126 days. From a construction standpoint. And so the Cherokee Nation very graciously allowed us to have close to 10,000 square feet of space within their community healthcare centers to use as classroom space for the students. So we were able to go ahead and bring students onto campus and not delay the start of our first cohort of students. The other thing that's important from a support standpoint is that this support didn't just come from the Cherokee Nation. At the time that we made the announcement on October 31st, 2018, that we were going to start the school, we actually had pledges of scholarship support, not only from the Cherokee Nation, but also from the Choctaw Nation and Chickasaw Nation, in 16 private donors to support scholarships to support Native students in attending school. And that initial scholarship drive resulted in $1.7 million of scholarship funds that are available for our students. As I said, we actually started classes at Cherokee Nation's community conference center. So it was about 10,000 square feet, and you can actually see that in this picture. Now, a couple of things that did is the picture that's in the top right of the honeysuckle pot. We had the opportunity to allow the students to engage in some of the decorating and art that went into the building. So one of the Cherokee Nation's National Treasure artists came in and taught a painting class, and the students were able, as well as the faculty and staff, to paint these beautiful honeysuckle pots. Now, part of why honeysuckle was chosen is in traditional Cherokee culture, honeysuckle was used to treat respiratory infections. It also happened to be orange, so it worked well with our color scheme. But given that we were in the middle of dealing with COVID and the challenges associated with that, this was what the students chose to paint to represent that experience. All of those pots went to creating a living donor wall that has different succulent plants in it, and it really is a tribute to people who are willing to donate their bodies for science and for our anatomy dissection donor program. So these are some of our students. They were very excited when we were able to move into the facility itself. And I want to spend just a little bit of time talking about the demographics of our students, because I get a lot of questions on, do you have to be Native to attend school at this campus? And the answer to that is no. You do not have to be Native. We are part of Oklahoma State University, so a state institution. So we adhere to all of the recruitment requirements associated with that. But we put a lot of effort and emphasis into how we recruit in the use of our pathway programs, as well as our post-bac programs, to support the diversity of the campus. So if we look at the class of 2024, which is our inaugural class, we have demographics here for both our Tulsa campus campus and our Cherokee Nation campus, because as I said, we recruit as a cohort and allow students to self-select which campus they would prefer to be on. Our Cherokee Nation campus in the class of 2024 is 22.2% Native American. Our Tulsa campus cohort is 12%. If we look at underrepresented minorities in medicine on our Cherokee Nation campus, that's at 31.5% and 24.8% on the Tulsa campus. And as we move to the class of 2025, which is our current first years, the Native American population is 24.5%. So really important to kind of understand. And if you look down towards rural Oklahoma, I said that rural was part of our mission as well. You can see that we have a large percentage who are coming from rural communities, and we define that as communities that are less than 7,500 people. So our learning environment is really important to us, because if we're going to put an emphasis on recruiting people, we want them to be successful in their medical educational journey. So we really think about our learning environment as consisting of four things: recruitment and retention, the environment itself, the formal educational experiences, and then the informal educational experiences. Brandon touched on some of our recruitment issues. We have a very extensive pathway development program targeted at Native American students in different communities. And that includes the programs that he touched on, Native Explorers and Native OK Stars. But we also do a program called Operation Orange. And the two pictures that are in this was the first cohort of high school students, so 9th through 12th graders, who come in for a camp where they learn suturing, CPR. Their parents have the opportunity to ask questions of the admissions and financial aid department. The students are able to see OMT demonstration, so osteopathic manipulative medicine demonstration. But the pictures that I put up there are when Chief Hoskin last year asked how many of the students in the classroom were Native to raise their hand, and you can see the number of hands. I would say probably 90% of the students, and we had 105 students there that participated that day, were Native students between 9th and 12th grade. So really great recruitment. Other programs that we have besides Operation Orange is Blue Coat to White Coat, which is a program with FFA. A lot of our students, we are in rural Oklahoma, are engaged in FFA leadership programs. And this is, again, a leadership opportunity to help support them in coming into medical school. We do Dr. Pete's Immersion Camp, which is a 10-day program where students have the opportunity to, very similar to the Native Explorers program that Brandon described earlier. They have the opportunity to come in and participate and see what it's like. We do a lot of pre-admission work, both a pre-admission workshop that's in the fall, but also MedX is an event that we do in the spring on campus, which again gives students the opportunity to come in, get exposure to what it's like to be a medical student, answer their questions, help them with CVs, personal statements, MCAT prep recommendations along those lines. So a lot really happens in that. Once they get on campus, we really want to support them in a learning environment that helps them feel comfortable. So there's a lot of things that are across the campus. We set adjacent to WW Hastings Hospital and across the parking lot from the Cherokee Nation Outpatient Health Center, which is an approximately 500,000 square foot ambulatory care facility that is a multidisciplinary facility. So we are on tribal land, we are on the Cherokee Nation reservation, and we are very thankful that we've been allowed to have this partnership and to be able to expose students as extensively as we have to Cherokee culture. So Talking Leaves, that's on the screen right now, is a library collection that we're in the process of building, and we would take any recommendations that you have. We funded this through grants, but we've reached out to the 38 federally recognized tribes that are in Oklahoma, to their cultural departments, and say, what books have been written by your tribal citizens, or do you feel represents your history? Really thinking in terms of telling stories and experiences, looking at health-related or adjacent books, looking at historical books and history that really begin to tell the story and the experience of the different tribes that are based here in Oklahoma. We have approximately 200 books today in the collection. It's my goal to get us well over 500 books and keep this as an ongoing growth process. The reason it was named Talking Leaves is when Sequoia developed the Cherokee Nation syllabary, there's a quote where he says that we need to develop talking leaves, referring to the paper that the white man has so that we can write down and retain our stories. And that's where the name of that collection came from. And Gina Elia, who was formerly the director of Cherokee Nation's cultural department, who also happens to be Wilma Mankiller's daughter, is who helped us come up with and name the collection. So we are very thankful for that. Additionally, throughout our facility, we have over 187 pieces of art from different Native American artists that really, again, tell the story of daily life, of family, of experiences. We have some clothing articles that are from before the removal, before the Trail of Tears, that are on the walls. There's traditional pottery, painting, basket weaving. Jane Oste is a Cherokee Nation National Treasure, and this was a quote from her about putting some of her art within the medical school. And any opportunity I have to educate people about our pottery and what we used it for and how significant it was in our lives is great. To me, food is pretty close to medicine because we eat and how we feel are so closely related. And so we tell the stories of the artists, and we tell the stories of what their art represents to them within their cultural context of how they view it. And that was one of the things that was really important as we developed the art collection in partnership with the Cherokee Nation, is allowing a venue in which the artists themselves are able to tell the story of their work. So formal educational experiences that we have, we've got some of them listed here. We have developed a tribal as well as a rural medical track. The rural medical track has existed since 2012 at OSU. We built off of that a tribal medical track. We use a distributive model for clinical education in the 3rd and 4th year, meaning students go out to different community training sites. We do have Oklahoma State University Medical Center in Tulsa, which is our academic healthcare center. But we recognized that where people train is where they're likely to go into practice. And so we give them the opportunity to do the majority of their clinical rotations within tribal healthcare centers or IHS facilities across Oklahoma. Now, obviously, they can't do every single rotation there. There's some things that they don't have access to. Inpatient pediatrics is currently one of them, but Cherokee Nation is opening a new hospital facility that will actually have a level 2 NICU in 2025. So we're very excited about that because that will change and allow us to keep the students on the tribal track actually within a tribal facility for their pediatrics, all of their pediatric rotation. Right now they can do 3 weeks, but they do have to get a NICU exposure as part of that rotation. We also offer early clinical experiences. Our students were very much engaged in Cherokee Nation pushing out their vaccine effort for COVID-19 under the supervision of faculty. The students participated in giving over 3,000 vaccines, COVID vaccines, to Cherokee Nation citizens. And we did that under the direct supervision of our faculty, but allowed them the opportunity to actually be part of the pandemic response. We have a lot of research opportunities for students with partnership with the Cherokee Nation, as well as the Muskogee Creek, Choctaw and Chickasaw Nation, so that they're able to develop different research experiences. And Brandon touched on Dr. Smith in the Office of American Indians, who provides a lot of support and a lot of mentoring on how we can partner between different groups to develop that. We offer a Cherokee language elective course, and we're currently developing elective courses in Choctaw as well as Chickasaw. So really developing a lot of things in the formal curriculum model. The other thing that I think is really important to share is part of this process, we've really looked at how we use language across our curriculum. So Brandon touched on the problems with sketchy and portrayal of how Native Americans were portrayed, but we've looked across our curriculum to make sure that we're using person-centered language, that we don't have any stereotype-based things. And this is an ongoing process because a lot of the curriculum lies with individual faculty members, but we do audit very aggressively to make sure that we are appropriate in our language. All of our simulation based experiences are high fidelity simulators. We ensured with the design of the school that we had representation of skin tone, and that may sound like a minor thing, but as we're working in developing cultural competency and cultural humility among our students, we wanted them to be comfortable working with people who look different than them. And we get this question a lot because people will look at the simulators, they're like, oh, well, it's a big plastic doll, but when students get into those clinical simulation-based experiences, they become very immersive. So making sure that we were respectful in that is really important to us. As far as the informal curriculum, we do a lot to support our students. We are very actively engaged in ensuring that they have opportunities. We have representation from the different tribes' cultural departments who come and will do art activities with the students. There's usually something about once a month. So they've done everything from corn husk dolls to beading to rock your mocks. The students had the opportunity to actually make their moccasins as part of an activity. They've done fry bread events. I'm sure Brandon can fill me in on all the ones that I'm missing and not highlighting appropriately. But we try to create space for them to express their cultural identities, how they're comfortable doing so. The other thing that we're very purposeful on is allowing students the opportunity to engage with their families. So if there's a cultural event that's important to them that requires them to step away from their studies, we try to talk to them about what the impact may be. We want them first to be successful in school, but a lot of times it's as simple as delaying when an assignment gets turned in or allowing them the opportunity to take a test remotely rather than on campus so that they're able to be with their family and honor their culture and heritage. The last part of our curriculum that is really important is residency training. Where do these students go when they finish their time with us? We're interested in the continuum of education and addressing workforce issues for rural Oklahoma and for our tribal partners within Oklahoma. So the development of residency programs in these communities is really important. And so we currently have 9 rural residencies that are accredited by ACGME. I want to highlight the 3 top ones on the list. So with the Cherokee Nation and Ada, there's a family medicine program that has a total of 12 slots. So they take 4 residents a year. Here in Tahlequah, we're up to 54 residency spots. So we're very excited. We've had a family medicine and an internal medicine program here. Starting in July, we have a pediatric program. It's a rural track of our pediatric program in Tulsa. As I said, pediatrics right now is a growing field. A lot of critically ill children in Oklahoma get sent either to Oklahoma City or Tulsa. With Cherokee Nation's construction of a new hospital, there will be a level 2 NICU here. So we anticipate being able to keep a larger number of pediatric students. The way that program is designed right now, about 27 of the 36 months of the residency program will be here in Tahlequah with the Cherokee Nation. The remainder of those months will be at OSU Medical Center in Tulsa or St. Francis so that they're able to meet their PICU and NICU requirements. We also have a family medicine program with the Choctaw Nation in Tallahena, Oklahoma. And then we have other rural programs across the state. In Lawton at Comanche County, we have a family medicine and emergency medicine program. In McAllister, there's family medicine. In Durant, there's family medicine. Norman, we have emergency medicine. In Stillwater, this past year opened a new internal medicine residency program. So I think that kind of gives you an overview of the work that we are doing and our mission and how we're approaching that here in Oklahoma. And I think I gave us plenty of time to answer any questions that you may have.
Dr. Bray, thank you for that excellent talk. Yeah, so I think that OSU is really a model for medical schools across the United States. So I was looking at the statistics on this, and it seems like only 10% of medical schools have any native content in their curriculum. So how have you been able to incorporate that into your curriculum?
So I think there's a couple ways, and that's part of what my job has previously been, is accreditation oversight and curriculum design. I think curriculum change, if you go to any curriculum dean and tell them you want to do curriculum change, their heads are going to start to, their eyes are going to twitch and their head's going to start to explode and spin. So I think more in terms of curriculum drift. So how do we begin to make small changes to the curriculum that incorporates these types of topics, but it's not an actual curriculum change? So I would encourage schools to do an audit of all of those clinical-based small group cases that you have, and ask the question, if it's a 56-year-old white male, do they need to be a white male? What's going to change if we begin to introduce cultural elements into these cases? So you're not actually changing the curriculum, you're looking at the diversity of the case presentations that are there to ensure that you're representing a broad population. And the easiest way to do it is to begin to ask questions. And, one of the presenters, and I apologize, I don't remember who it was earlier in the talk, talked about, the health disparities affecting Native Americans. So look at those big health disparities. We know that Native Americans have a higher rate of diabetes. We know that there's an increased chance of dying from heart disease or from cancer. So pick one of those. If you need just, proof of concept, pick one of those topics and look at the cases around that and begin to integrate it in. So it's an easy change, to be honest, but you begin to start to make those small incremental changes in the diversity of the cases, and you begin to integrate the topics, because now when we talk about it, we're not just talking about the medicine. We're talking about who the person is within the social and cultural context of what is contributing to their health and what barriers they may have in defining what health means to them, and how that comes up against our healthcare system, and how we, with Western medicine, and I use that broadly because everyone on this call is involved in medical education, but how we don't always take into account of who the person is and their multifaceted true self. And we want them to conform to how we view things and how we feel that they should be happening. And so maybe we don't solve the problem because there's not a right answer, but we begin to challenge the students to at least see things from a different lens.
Right. Yeah, and the other thing that I'm struck by is, how successful you are in recruiting Native students. So I guess, what advice do you have, since most medical schools don't have any Native students, what advice do you have for other medical students that might want to increase the diversity and recruit Native students to their own schools?
Yeah, so I have to say I have a wonderful admissions team. So I think that's important to say, but I think it goes to some of those pathway programs. We have partner elementary schools in 4 different communities, and our elementary programs, I will say, are much smaller than our middle school and high school programs, because we physically take students into those schools. And so we want it to work with the medical student with their schedules. So we encourage that outreach, right? We want to take medical students like Brandon, who are so talented, and allow the kids to see this is someone who looks like me, who came from my town, who has similar experience as me, and they can be a doctor. So we begin those conversations very early. And OSU has done a great job as far as our reach out into the communities and how we support that. And I think that begins the conversation. The second thing is we support our students, and someone else spoke about this too, in their application process. So if they come to our if we see them, in Operation Orange when they're in high school, we're reaching out to them when they're in college and inviting them to MedX, or inviting them to our Native Explorer programs where they're coming in. We talk to them when they apply about if they're not quite ready to be successful in the medical school curriculum, can we support them by getting them into the post-bac program and support them in that? And our post-bac program is grant funded, so the students they pay fees, but they don't pay tuition for that year. And so it gives them the opportunity, not to accrue more medical student loans as part of that process, but they are able to be in with the medical student cohort and take some of the classes. They get a certificate in biomedical science, or they can get a master's degree, depending on where they are in that developmental journey of what they need for success. And we support them in that, and we prioritize supporting the students. And I think that that's what's important, because then that word begins to go out. We have other programs that I didn't touch on. We have a 3+1 program where we go to a lot of the smaller colleges that have a large Native American enrollment across the state, places like Northeastern State University here in town, and our regional university network that have high enrollment of Native Americans. And students who meet qualifications can finish their first 90 hours. They matriculate as a medical student. And once they finish that first year, they're granted their undergraduate degree from what the primary university is. And so again, it gives them an opportunity to really be engaged in the process from we start talking to those students in their freshman year. Is this something that you might be interested in? You're a pre-med. These are kind of the classes that need to line up for you to be successful and engage in this program.
Yeah, excellent. And so I have one last question. So it sounds like you have a pretty strong relationship with the Cherokee Nation. And so I just want to know about what kind of things you're doing to actively build trust and relationship with the Cherokee Nation.
A lot of it is listening. And I mean that very sincerely. Our president for the Center for Health Sciences meets with Chief Hoskins, Chief of Staff, on a biweekly basis. I meet with the director of Cherokee Nation Health on a weekly basis. My director of operations meets with the external affairs team on a weekly basis. So there's continuous ongoing communication in listening to what are the challenges, what are the needs, how can we do better? We work closely with their physicians as far as doing physician CME-based training. So we get a lot of questions around where they've identified a need, and we try to step into that space. If they have educational needs in different departments, we allow them to use our simulation department. We work with them to get CME and nursing credit for different things. They're currently trying to get certified as a stroke center, so there's a lot involved in that. And it's that ongoing conversation to say, we are not the Cherokee Nation. I can't speak on their behalf, but I can listen and I can work with them to understand where they're seeing barriers, where they're seeing challenges, and how we can work together to meet that shared need. Because really at the end of the day, we want what is best for the patients that we serve. And we reach that outcome by producing quality physicians. And we have to get that feedback, and we have to hear what we're being told.
Right. All right, well, Dr. Bray, thank you very much for your talk. It sounds like OSU is an excellent medical school, and I hope that other medical schools follow your lead.
All right, thank you so much.
Yeah, thank you.